Boy, so what makes ruxolitinib such a perfect drug for atopic derm is that it starts to work on the itch in 15 minutes. Patients want an as-needed drug, right? When they have topically treatable disease, that is the perfect as-needed drug because, like, imagine if we had an acne drug where we said to our an acne topical where we said to our teenager, "Hey, put this on, and by the time you get back to school in 15 minutes, your acne will be mostly better." Right? Or psoriasis topical. Hey, put this on. By the time you get back to work, the redness and flaking will be gone. Like, that's insane, right? So that's what makes it such a perfect drug. I would say what maybe could make it better uh, would be from a medical perspective, larger containers to sort of increase who we can treat. Uh, Maybe something that was indicated QD instead of BID, although my patients pretty much all use it QD, and something that really had less systemic absorption. So even though I have no concerns about the risk associated with topical ruxolitinib, there is 6% systemic absorption. So if you treat a big enough area, you probably are getting some systemic JAK effect. You can't treat a big with 60-gram tubes. The amount the disease size that you could treat is small enough that we don't have to worry about that at all. But if we got to larger containers, uh, we would either need a lower concentration or less systemic absorption if we wanted to use it on big body surface areas. Boy, I am doing a clinical trial with a new JAK inhibitor not currently in the market for HS. Never seen anything remotely like it. I mean, this has to be the way that the first investigators who did dupilumab clinical trials felt and be like, oh my God, that's what JAK inhibitors are like for HS. And, the existing data that's out there for upadacitinib, 100% of people got 50% better. 90 some percent of people got at least 75% better. It is insane how effective these drugs are. And don't forget, that's as monotherapy. So my firm belief is that once we really have JAKs for HS, we may put somebody on some antibiotic and a JAK. I think that's going to have incredible efficacy. And then we stop the antibiotic and just maintain them on the JAK. I think doing that, combining it with intermittent oral antibiotics as needed, the topicals that we've always used. I think it's going to turn HS into an easy disease to manage. Is what I really believe based on what I've seen so far. And the 30-second elevator pitch for a JAK inhibitor, the 10-second elevator pitch is prednisone with no side effects. Right? If prednisone works, a JAK inhibitor will work. If JAK inhibitors get to where they're someday where they're cheap and easy to prescribe, it'll be everything, right? Like lichen planus, granulomannulare, pyoderma gangrenosum, sweet syndrome, all of the really hard stuff to treat is going to become pretty darn easy to treat if we get cheap, easily accessible JAK inhibitors at some point, which at some point we will. Maybe that's going to be 5-10 years from now before they go generic. But it's going to make a big difference. It's going to make a real big difference.